Good morning and thank you for joining us for this edition of Eye on New Mexico. Well, we have a problem here in New Mexico. It's called opioid addiction, and sadly, too many people are dying from it. At the beginning of this year, the Centers for Disease Control and Prevention reported New Mexico's drug overdose death rate improved from 49th worst in the nation to 43rd. Now, there's even more good news for our state. Our state saw a 7% drop in drug overdose deaths from 2014 to 2015. But at the same time, the nationwide overdose death rates went up nearly 11%. Now, the CDC says 78 people die every day from opioid overdose addiction. Well, here's what our state is doing to crack down against this problem, and we're doing quite a bit, actually. In February, Governor Susana Martinez announced a $200,000 grant from the drug company Pfizer Incorporated for the naloxone access program. Our state is one of 5 that's receiving grant money to increase public awareness of the risks of opioid addiction. Now, in 2014, our state became the first one to provide pharmacists with prescriptive authority for naloxone. You might be asking, what exactly is that? It's an antidote that can reverse an opioid addiction. And late last year, Albuquerque City Council approved a measure to make it easier for people to access. City facilities, from libraries to pools to community centers, now have those on sites. Employers are trained on how to use it. Well, joining me on the panel today are 2 people who are very well versed in this area. Jacob Vigil is an assistant professor with the UNM's Department of Psychology. Associate. And we have Dr. Anthony Reeve. First off, thank you guys so much for joining us. Now, when it comes to opioid, the word gets thrown around a lot here. What exactly is that?
Well, an opiate is a class of medication. It's generally known in the public as a narcotic. But there are many forms of opiates, and the most classic form is oxycodone, hydrocodone, and that entire class of medications. But there are several medications that would classify for opiates. In New Mexico, we consider tramadol a scheduled substance because it is an opiate-based substance.
And why are they prescribed?
Well, classically, pain medicines are prescribed for pain. And traditionally, there can be post-operative pain after surgery, and patients who have acute pain from fractures or things of that nature. And then there's the subclass of patients who are chronic pain patients, which is what I deal with a great deal in my practice.
And when it comes to the factors of taking those, I mean, they can be pretty addictive, correct?
Yes, they can be very addictive.
Sure. In fact, you know, several studies have shown that 90+% of new heroin users actually first got started being addicted to opioids, only to turn to heroin, to street heroin, as a cheaper alternative. So the fact is that our prescription pain-killing practices here in the United States are ultimately creating heroin addicts.
So how long does it take from that person to go from a prescription drug that was prescribed by their doctor to go to street heroin?
Well, different folks are more or less susceptible to this sequel A, but the fact is that the modern face of heroin users is changing, and it's directly reflecting our prescription patterns out there.
And what are doctors doing to address that problem?
Well, in the state of New Mexico, there's been very significant pushes to reduce opiate use among patients. And one of the main pushes that was just enacted into legislation in 2017 was the physician monitoring program has been updated to reflect that all physicians who are prescribing opiates for more than 4 days are required to do a pharmacy background check on all patients. The pharmacy background program is a program that requires all pharmacists and pharmacies to register these opiate prescriptions on an online program that must be reviewed when prescribing these type of medications.
And how are doctors reacting to that sort of legislation?
Well, I think there's mostly acceptance that we have a significant problem in the medical community and with prescribing these medications. And I think they're, of course, going to do these background checks because we're required to do it to maintain our license.
When did we start seeing this problem come about?
Well, we've seen different waves of heroin use affect our society throughout the years. Largely, the increases in opioid-related causes of death have really started to peak about 10 years ago. And right now we're on an upward trajectory, and as you alluded, there's no end in sight. So in 2015, there was about 52,000 Americans that actually overdosed on drugs. It was about 148 people every single day. Now, the important point that I think that people need to understand is that currently there's more people that are overdosing, particularly on opioids, than are dying in car accidents. Now, this should be shocking to folks, given that cars are flying through the air at fast speeds that are carrying people in them. You know, obviously that those are a tremendous form of death, gun violence as well, but our opioid epidemic is actually killing more folks than gun violence in cars.
So it's a public health crisis.
Like we haven't seen before.
You know, we mentioned here that New Mexico is doing something to help address these problems. What more needs to be done to get us from that 43rd ranking to even higher, maybe number 1, being one of the best in the country for fewer deaths?
Well, one of the questions you asked me is what else are we doing here? And so in New Mexico, the physicians are required to do urine drug testing as well. And so that's a very important component, because you need to validate that the prescriptions that you're prescribing are actually being taken by the patient you're giving them to. 50% of the overdose problem that we're having in the state of New Mexico is due to diversion, which is to say that patients are selling their drugs to other individuals who then go on to overdose and die. So one of the things that we're doing in New Mexico is we are requiring the physicians to drug test. So when you are on these medications, you must go into your doctor, and your doctor will ask you to pee in the cup, so to speak, and that'll be sent off to a laboratory for confirmation to verify that you're indeed taking these medications and you're not also utilizing other illicit substances concomitantly or at the same time with the use of these medications.
You know, we've seen several stories where people who say they've come back from this sort of addiction, that while they were taking it, I mean, it just did wonders to them. What makes these drugs so addictive? How does it affect the body physiologically?
Physiologically, opiates attach to the mu receptor, which is a receptor in your brain. It's very akin to the euphoria receptor that you get with very pleasurable activities. And so that particular receptor in the human body tends to reinforce and reemphasize pleasure and euphoria. And so that is a very addictive thing for human beings.
Mm-hmm. Now, from what you've gathered in your research, what other things about these types of drugs should people be aware about?
Well, you know, not only do they pose a tremendously high risk of overdose, but opioid use is associated with greater risk of accidents, heart disease, greater risk of all types of complications, gastrointestinal complications. Sometimes this even results in rupture. So relatively speaking, opioids are a very dangerous form of drug, and we tend to prescribe them very differently in the United States than we see in other countries. In other countries, we tend to prescribe hard opioids for acute hospitalizations, for burn victims, for significant operations, for women that are going through labor, end-of-life care, and so forth. Here in the United States, unfortunately, we're prescribing rather indiscriminately. So folks have access to, for example, hydrocodone right around the corner at your local dentistry.
You know, we've done several stories where, say, a high school athlete gets injured during a game and has to take opioids to counter that, and that's kind of where they say their addiction starts. Are we seeing that more often with younger teenagers?
Well, I think as more and more physicians are educated and more providers are educated, I think you're seeing that less. I think that opiates should not and are not being used as first-line medication, and I think a lot of clinicians are using nonsteroidals, anti-inflammatories, or a lesser form of pain management. But let's not forget, there are true patients out there who are in serious, critical pain. And a lot of people discount them as being liars, malingerers, or abusive. There are patients, and in my own practice, who do require more than just anti-inflammatories and common medication. So I think this is where you need to be an experienced clinician to differentiate that population, and we shouldn't make sure that patients who really do need pain medicine don't get that pain medicine. So it's kind of a fine line, and we as a society and as doctors, we need to come to grips with where that line is going to be.
Mm-hmm. And in 2014, we mentioned that the naloxone prescriptive authority was kind of widened. What is naloxone? People, when they hear about it, they're like, well, what is that exactly? It's an antidote, but how does that work?
It's really more of an antagonist. It antagonizes the use of the opiates. And so in that extent it helps, but it isn't a cure, and it isn't a substitute, and it may help with withdrawal symptoms, but it doesn't take away the problem that we're facing. And that's part of what some of the research that we were doing through Dr. Vigil is kind of having some bearing on that exact question.
I think it's important for folks to understand that opioids don't cure chronic pain. So it's not the case that your pain is going to be reduced 6 months, 9 months down the line, or a year and a half down the line as a result of taking or frequently using hydrocodones. It's just not the case. So they have short-term efficacy, but their long-term benefits are largely don't exist. They just don't exist.
What is the state doing in terms of outpatient services or treatment facilities for people who do have addictions to these drugs?
Well, I don't know that I'm really qualified to answer that question. I mean, it's a good question. I do know peripherally that there are addiction centers, that the state funds it through Medicaid. I don't know the extent to which that is occurring. I'm not an addictionologist, and I don't practice in that area of medicine right now.
Let me just note one particular research study that some of our colleagues at the hospital are conducting now. So they're actually giving these antagonists that you're referring to directly to the heroin addicts. And what these patients are reporting is that they've been able to use these fast-acting antagonists to save the lives of their friends during an opioid episode. So in terms of the benefits of these particular antagonists, they are effective at reversing the immediate effects of overdose on opioids. And that's just one of the programs. So basically we're talking about an initiative where we're allowing patients to not only self-monitor but access their treatment on their own, which is essentially a paradigm shift, and it's one that the medical cannabis program is following.
Yeah, so briefly we're going to talk about that in the next segment, but what does that program do?
The medical cannabis program? Sure. It was enacted in 2007. The basic idea is to provide patients that are dealing with chronic debilitating health conditions the opportunity to self-manage and self-medicate through cannabis in ways that they have been unable to find either safe or effective remedies through conventional medications.
And you're seeing this being used in your practice as well?
The medical cannabis program? Yes. There's over 30,000 medical cannabis license holders, so probably every physician in the state of New Mexico is seeing some patients on medical cannabis. And
some of the results that you're seeing, good, positive?
I would say the results overwhelmingly have been positive for the patients who elect to be on medical cannabis, and I've seen a lot of patients be able to get off of opiates altogether or reduce their opiate use, which is substantial as well. And quality of life reported, at least anecdotally and subjectively, is much better, yes.
All right, excellent. When it comes to these types of programs, sometimes they get bad reps. Briefly, tell us, how do we get past that?
Do you mean like how does society get past those issues? I think clearly education. The most important that I can see is research. And this is a huge problem in the United States right now because medical cannabis or cannabis is a Scheduled I drug, which means you can't do real research on that medication or substance. And we need to be able to do the research, if nothing else, to prove what the government says, that it should be a Scheduled I. In my opinion, it probably shouldn't be a Scheduled I, but we need the research to say yes or no.
Excellent. All right, well, that's going to do it for our first segment here. When we come back, we're going to talk more about the possible alternative to opioids being used for pain. We're just talking about it right now, medical marijuana. We'll be right back. Welcome back. In our last segment, we explored the problem of opioid addiction here in New Mexico. And while the state is making strides in preventing addiction and even death, there's still a lot of work to be done. Our guests today are two researchers who are also assistant professors from UNM, Jacob Vigil and Sarah Stith, and they held a presentation at UNM on Friday, and it was called The Effect of Enrollment in New Mexico Medical Cannabis Program on Prescription Opioid Use in Chronic Pain Patients. So first off, tell me a little bit about this study. What were you guys looking for, and what did you guys find?
Sure. So following the anecdotal observations of Dr. Reeve, and again, him noting that it seems as though patients are reporting their ability to come off opioids as a result of enrollment in the program, we essentially wanted to conduct a study to assess the veracity of those claims. So this is one of the first studies in the country here in the U.S. to actually measure the effectiveness of a medical cannabis program for affecting patient well-being. So we ultimately designed a study around a cohort research design, which is basically following patients that chose to enroll in the medical cannabis program and looking at them over time in terms of their narcotic use and comparing them against matched controls that had a similar diagnosis of chronic pain who did not choose to enroll in the program. And we essentially followed them over time, and we are looking at their narcotic prescription use. And we also took the opportunity to measure patients' satisfaction with the medical cannabis program in general, as well as their pain levels prior to enrollment in the program and their current pain levels. And we actually found some remarkable results.
Well, yeah, this program started in 2007, and there's 35,000 patients enrolled in it here in the state. What did you see in terms of the results of after following these people and their use of narcotics?
Well, the results are really pretty dramatic. We measured whether they ceased opioid use. We measured whether they reduced opioid use in multiple different ways. We looked at their usage over time. In all cases, we see a statistically significant reduction in the amount of opioids the patients in the cannabis program are using relative to our comparison group of chronic pain patients.
And how long did they start making those decisions to reduce their narcotic use?
So we look at the patients for the first 3 months prior to enrollment in the medical cannabis program to establish what their usage was. Then we follow them over time, and we look at 18 months or a year and a half after they enrolled in the program, were they still using opioids. We also looked at 1 year post. In both cases, well, not a majority, but around 40% had eliminated opioids, and 80-something% had reduced. Now, these are, of course, preliminary findings. These are not yet published or peer-reviewed, so I want to temper them a little bit. But certainly the preliminary results look very convincing that at least for these patients, cannabis is really helpful.
I think something important to note is that the cannabis patients actually started off taking higher amounts of narcotics. And by the end of our observation period, they were taking lower amounts of narcotics than our controls or comparison group that was not enrolled in the program.
So the comparison group stays pretty flat in their usage, whereas we see the decline.
So you saw a pretty significant difference then?
Yes.
I mean, when we see this, what are some of the long-term implications of the findings of this research?
Well, one is that it seems as though cannabis may be able to be used as a safer and more effective treatment for chronic pain. As I mentioned before, chronic opioid use doesn't seem to have long-lasting benefits for folks that are dealing with pain. Now, what we found is that patients seem to be willing and anticipating and really benefiting from the option to utilize cannabis as opposed to opioids. So they're preferring cannabis to treat their pain, and as a result, their opioid use has gone down. We fully believe that both the effects on opioid reduction and its ability to treat chronic pain at this point in our study does justify, at least in our minds, the rescheduling of cannabis sativa nationwide.
And I think also it justifies, we should mention, this was not a large study. This was from one doctor, one clinic. So what really I think the next step here is that we need the funds to be able to do a broader study with more patients and see if, there wasn't something just specific about that group we looked at. We want to see that, it holds up in the general population as well.
We talked about the addictive properties of opioids. What about for cannabis?
Sure. Well, we know that cannabis can be addicting. So whether or not people are healthy or they have cancer or they're dealing with arthritis, cannabis tends to make people feel better, and they tend to repeat using cannabis. But what we're talking about here are the relative risks involved. So one of them is associated, opioids in particular, is associated with a whole host of very lethal outcomes. Cannabis, by all standards, at least according to review articles that have been recently published, is not associated with a single documented case of lethal overdose in history. Now, again, certainly cannabis is probably not ideal for people that don't require medical uses for it. Certainly, we would want to restrict it from children. But again, we're dealing with the relative risks involved and the conventional options that patients have available to them in 2017. And it looks as though we have a very optimistic future ahead of us if we can manage as a society to entertain a broader range of alternative medications.
And when it comes to medical cannabis, I know that before there were people who were experiencing a backlog and trying to get a card. What challenges do people face in terms of getting access to medical cannabis here in New Mexico?
I think the number one obstacle is the legal hindrance, right? So a lot of folks are scared about getting in trouble. And again, these are folks that are usually taking cannabis, at least in terms of the adult population, to ail some sort of, to remedy some sort of ailment that they're dealing with, whether it's their inability to sleep or their inability to remove themselves from obsessive thoughts and dealing with anxiety, PTSD, their inability to remove themselves from the chronic pain that they're experiencing. So the fact is that most adults are using it to self-medicate on some level, and the presumption is that that use can be conducted responsibly with time and perhaps with proper education.
What other challenges?
There's certainly still social stigma, and actually this patient population is they're not who you normally think of as sort of your pot users. These tend to be older folks. The average age in our samples around 55. So these are people who are not coming from a background where they think that cannabis is something that's generally should be used. So they're really coming to it as sort of the opioids are no longer working for me. What else can I do?
So the physiological responses between opioids and medicinal cannabis, do we know what differences they cause in the body? Like why this group that you guys been tracking was able to reduce significantly their use of narcotics?
Well, the fact is that we don't know very much about the true safety and medicinal benefits of cannabis, largely because of the prohibition that researchers have been under for a long time. Now, with regard to pain is complicated. So there's really an attentional distractionary component that a lot of researchers really aren't even tuning into. So it could be possible that there's a central nervous system effect, a peripheral effect, and it could be simply that the cannabis is causing folks to distract from obsessing, for example, over their ailment or the aversive sensations that they might otherwise be exposed to. So there's multiple mechanisms by which cannabis can be potentially reducing pain.
And I think also just with relative to the opioids, one major side effect from opioids is constipation, and there are even drugs out there now to treat opioid-induced constipation, or OIC as they call it. There's no evidence that cannabis causes constipation, and as it turns out, among opioid patients, this constipation can even lead to death, to bowel rupture.
When it comes to research with marijuana, it's limited across the country. What are some of the setbacks that can cause for research programs like this?
Well, I think as a society we've largely been constrained from the opportunity to truly estimate and compare alternative medications. So we're talking about something that's absolutely natural, maybe even one of the most natural products that a patient has ingested throughout the whole day. But there's tremendous opportunities. A lot of folks are pessimistic, presumably with the new administration. I truly believe that we're on the cusp of the golden age of medical cannabis research here in the United States. And also we have tremendous opportunities here in New Mexico, given all the vast resources, the implementation of our medical cannabis program, a very eager patient population and community resources spanning dispensaries, certified laboratories, and so forth, that we as researchers can utilize right now to do remarkable work. All we have to do is be willing to stick our necks out.
There are some states here in the country that have pretty lax laws when it comes to marijuana in general. When it comes to those types of laws that create a more lax environment, does it kind of put New Mexico behind, so to speak, in terms of being the front runner for finding out what kind of properties that these hold that they could eventually do to create beneficial impacts for people in pain or whatever?
Sure. I think
it could go really either way in terms of sorry, I lost my train of thought there.
Yeah, I was just going to simply say that we have a really pure patient population here. It hasn't been adulterated by the recreational market, and this is really beneficial from a research standpoint because it allows us presumably to address the types of patients that are in true need.
So we were talking about the next steps for what's going on. You guys focused on one doctor and his or her patients. How do we go about going further?
Let me just mention really briefly, I actually started what's called the Medical Cannabis Research Fund at the University of New Mexico. So this is a mechanism for the general public to be able to donate and support the type of research that they feel is necessary and helpful for their family, their community, and so forth. The reason why I started this is because it's incredibly difficult to get federal funding for conducting research. And more so, some of the federally funded research programs out there lack aspects of scientific validity. We actually wrote about this in Science magazine a couple months back. So for example, some of the studies that are funded currently are measuring cannabis with THC levels that are very, very low, like 3%, which doesn't resemble anything that patients are using. So even though these studies are costing millions of dollars, they're very limited in how generalizable and how relevant their findings are.
Wow. And how's this fund doing?
Well, it's doing well. So we've been able to embark on a number of different studies. We currently have another study that's open and open to enrollment, where we're essentially assessing about 1,000 patients, and we're looking at how involvement in the program and cannabis use in general is affecting not only pain, PTSD, depressive symptoms, quality of life, physical well-being, and so forth. Likewise, we're also engaged in numerous studies across the campus, basically investigating, everything under the sun in terms of the true safety and medicinal benefits of cannabis for treating a number of different types of conditions.
And I think also looking into the policy issues, the cost effectiveness issues, quality control, and sort of more on the public policy side as well.
Well, talking about the public, like the perception of marijuana has definitely changed in the last few decades. Some people might argue that in the next few, it'll definitely change even more so. How will that affect research in terms of the medicinal purposes for marijuana?
I'm not sure it's changed maybe quite as much as what you were saying in the academic population.
Okay.
I think in the public, yes.
Yeah.
But there's still a lot of resistance, I think, in academia. But as there's more and more pressure from the public, that should loosen things up on the academic side.
I mentioned that we have tremendous opportunities, and the reason why is because a lot of basic science hasn't been conducted. It should have been done about 100 years ago. So we don't even know how relative ratios of different cannabinoids might affect pain perception or anxiety levels and so forth. So, the simple distinction between cannabidiol and THC has largely not been investigated in human populations using natural whole cannabis, the flower itself. So most of the studies out there are dealing with animal models, or they're dealing with synthetic extraction techniques. And again, these types of studies don't resemble what patients are actually utilizing to self-medicate every single day.
In both the benefit side and the risk side, of course.
True.
If we're talking higher doses, so either side could be affected.
Excellent. Well, Dr. Stith, Dr. Vigil, thank you so much for joining us today. That is going to do it for this edition of Eye on New Mexico. We're going to be back next weekend, and we'll see you then.